So we are talking about the three different options: chemotherapy alone, chemo-radiation, or short-course radiation. And the proposition is that chemo-radiation is preferred over the other two options. That's the case that I'm going to make, and I would agree with Dr. Schrag that there's no evidence that this can be replaced by chemotherapy alone. And what I'll try to do is show you why chemoradiation should be the preferred choice. Now, I've made some assumptions. Number one is that we're talking about patients who need preoperative therapy. There are a lot of clinical trials that have been done and have included patients that didn't really need preoperative therapy at all. But I'm talking about a patient with a T3, T4 node-positive tumor or a mid to low rectal T3, T4 node-negative tumor. I've also made the assumption that the goal is cure, which would require elimination of all of the local regional disease. And the final assumption is this is a debate, so I feel less constrained to be balanced. Now, one thing that we should note is that there is an intermediate risk group with one risk factor, either node positive or T3 without node positive disease. And this is the old Gunderson analysis. These are post-op trials. But even with surgery alone, and largely in the pre-TME era, most of these patients do not have local relapse. These are local relapse numbers. And the reason that's important is it is true that we're over-treating a lot of patients, but it's also true that in the adjuvant setting, you really can't draw any conclusions about a single-arm adjuvant pilot study. It doesn't really tell you anything about whether that treatment is effective or not, because you could study anything in this group of patients and conclude that 90% of them don't have local failure. In fact, even in the high-risk group, the local failure rates, as shown here, are quite low, although radiation chemotherapy has the best local failure. And these are survival from the Gunderson analysis, where for most of the high-risk stages, the chemoradiation survivals here are better than the chemotherapy alone survivals. And this is the kind of patient you don't want to ever see in your clinic. This is a 30-year-old patient who ended up with the local recurrence as seen here. Quite a miserable situation for the patient. So let me just show you one case. This is a patient that I saw a few years ago. She was diagnosed at a young age while she was pregnant with a very bad rectal cancer. She had a T4 lesion. She had 5 positive nodes. She was absent MSH2 and KRAS mutated. And for whatever reason, it was decided to treat her with post-op, FOLFOX and Bev, no radiation. Probably not the best decision. 18 months later, she had left leg pain, and I'll show you the images. You can see a very large pelvic recurrence involving the sacrum posteriorly here, and see the tumor extending into the bone. And you can see why she had pain. Here's the coronal image with the sacrum and the nerve roots, and you can see extensive infiltration of the nerve roots by this tumor, which was unresectable at this point. Well, that's just an anecdote. So what's the level 1 evidence that supports chemoradiation therapy as the preferred strategy? And I'll just show you a few randomized trials. Some of them have already been mentioned. But historically, this is a very important trial. The GTSG study had 4 arms. It's a small study, older, but it really did establish that chemoradiation therapy improves both survival and local relapse. Chemotherapy alone did not improve local relapse, had no effect on local relapse, in fact, and really no effect on overall survival. Radiation without chemo, similarly, did not have much effect on local recurrence and really no effect on overall survival. So this study really established chemoradiation as the standard. And then, as already been mentioned, that was a post-op approach. The Germans looked at the post-op versus pre-op, and I'll just briefly show this data. What they showed is that there's no difference in overall survival or disease-free survival, but you have fewer local recurrences if you give the chemoradiation preoperatively. They didn't really see a difference in the distant metastatic rate. And these are the local relapse curves. This is with preoperative treatment, only 6%, and about double that with postoperative chemoradiation therapy. And interestingly, they also noted that it's probably important how the radiation is done. These are patients who had adequate radiation, that's their local relapse. And these are patients whose radiation was deemed inadequately done, and you can see it was about 20+%. And then the worst group was this group of patients where these were patients that were supposed to get radiation per protocol, but for whatever reason didn't get it. It was indicated but not given, and they had a 30% likelihood of local relapse. and that is with the TME operation. Probably more importantly, though, is that preoperative radiation therapy is associated with significantly less toxicity, both acutely, where any grade 3 or 4 toxicity was 13% lower with the preoperative approach, and probably more importantly, the late toxicity was significantly lower, 10% lower in the preoperative approach. So really making this the preferred method. So we have level 1 evidence that chemoradiation impacts local control and survival, and we have level 1 evidence that preoperative therapy would be better than postoperative therapy. So what's the evidence that supports chemo alone without any radiation? And the answer is there really isn't very much. Going back to the GTSG study, really no impact of 5-FU in the adjuvant setting. It didn't impact local recurrence at all. With surgery alone, it was 24%. It was 27% with chemotherapy. And the EORTC did a randomized trial trying to look at the impact of chemotherapy, and they had 4 arms. One of them added chemo to the radiation, and the other 2 arms looked at postoperative chemotherapy, so they were looking at both the issue of adding chemo to the radiation and the post-op adjuvant chemotherapy question. And these are the survival curves in the initial publication, and while it does look like there was a little bit of separation for the post-op chemo arm after 5 years, the p-value was not significant. And in the updated analysis, these are the survival curves shown here for all of those arms. Really couldn't demonstrate that there was any survival impact of giving adjuvant chemotherapy in rectal cancer. Kind of looks like stage 2 colon cancer studies. So there are a whole host of negative phase 3 trials looking at adjuvant chemotherapy for rectal cancer. The data is really lacking. The GTSG and EORTC, which I showed you, there's an Italian study, Chronicle study, which closed early because of poor accrual, and the Proctor Script study, which also closed early for poor accrual. So there really isn't good data to show that local control and survival are impacted by chemotherapy in patients with rectal cancer. Now, here's probably the real issue. Since we know that chemoradiation has a favorable impact, the real question is, what's the impact of pelvic radiation on the bowel function? And this would really be the only reason to consider not giving radiation therapy in these patients. And here's some data. This is from 2 North Central studies, 250 patients who had pelvic radiation, a variety of malignancies on 2 studies. And what was seen there is the number of patients that had 5 or more bowel symptoms, it increased from 2 to 13% with pelvic radiation. And so about 10% of patients had an increase in their bowel symptoms that were significant. If you looked at patients that had none or up to 2 symptoms, that was 80% at baseline and 66% at 12 months. And importantly, there was no significant impact on patient-reported quality of life as a result of pelvic radiation. And this shows the various symptoms here. The black bars are their baseline levels for these symptoms. The white is at 12 months and the gray is at 24 months. And so while you can see that radiation definitely has an impact on bowel function, the number of patients impacted by each symptom is actually quite low. And in fact, the only symptoms that had a significant change from baseline to 24 months were these 3, incontinence, clustering, and protective clothing, and they were all less than a 10% increase. Not insignificant for the patients that suffer these symptoms, but 90% of patients after pelvic radiation therapy really don't have bothersome bowel function symptoms. So finally, just a couple words about short course radiation. We already saw this study briefly, but just to make the point, a couple of points here. The Dutch randomized study looking at TME alone or TME with short course, 25 and 5, did show better local recurrence compared to TME alone. So you do have level 1 evidence that short course radiation does impact local control. One thing you should note about this study is they included everybody, stages 0 to 4. So a lot of the patients on this study didn't need any preoperative therapy. And if you look at just the stage 3 component, even with a TME, the local recurrence rate was 21%, not 50% as it used to be, but still quite high. Importantly, though, there was no difference in overall survival. So no evidence from this study that short course radiation has any impact on survival. There have been a couple of studies looking at short course versus long course chemoradiation, but it's important to note neither of those studies were really designed as a comparison between these 2. This Polish study had an endpoint of a 15% increase in sphincter preservation, which is actually not a very good endpoint since it's surgeon dependent, so it's really a poor endpoint to use. But nonetheless, if they didn't find a survival difference, but if you looked at the pathologic complete response rate, better with chemoradiation, positive margins, better with chemoradiation, only 4%. And again, I would note that a good number of these patients were T1 and T2 patients, almost half the patients on the study that probably didn't need any preoperative therapy. There wasn't time for downstaging, so this means that initial diagnosis on this arm, 40% of the patients were T1 or T2. And also I would note that if you looked at the late colostomy rate, it was 17% with the short course and 8% with chemoradiation. There's also an Australian study, the same randomization, but again, not powered as an equivalence study. This study, they powered it to look at a 10% increase in local recurrence with short course. And you can see the local recurrence rates were low on both arms, but the pathologic complete response rate much higher with the chemoradiation arm, and maybe more importantly, if you looked at distal cancers, the local relapse rate was 13% with the short course versus 3% with the long course chemoradiation. And since this is a debate, we can do this. These are the short course chemo trials. If you look at 5-year survivals here for 5 randomized trials, and here I found 3 trials, all of which have higher survival than any of these studies. So to conclude, I think we would have to agree that chemoradiation shows a survival benefit and a local control benefit in the postoperative setting. We can see from the German study that preoperative chemoradiation is better than postoperative. We're really lacking in data for benefit of chemotherapy alone, and what we actually need is a study in intermediate risk patients with chemo alone without radiation to demonstrate that chemotherapy has an impact on local control or survival or a meaningful endpoint, and that's lacking to date. Bowel toxicity is an issue for some patients, but not bothersome for most. And short course radiation therapy, while it does improve local control, the evidence of a survival benefit is lacking. So I would conclude that chemoradiation is the preferred strategy as preoperative therapy for rectal cancer. And if you use that strategy, you'll be less likely to see this patient in your clinic.
Mike, speak up here.